Good afternoon. Welcome to another Live and Learn with Blanchard Valley Health System. I'm Bill Coase, one of the medical officers here at Blanchard Valley Hospital, and I have my friend with me today from the pulmonary department, Dr. Fadul, who's going to talk to us about several of our problems that have come up related to COVID. But I think before we start, how about, Ralph, you tell us a little bit about yourself, about the department, who's in it, what you do, what is a pulmonologist, how do you work with intensivists? Before I have him do that, one of the things that we've tried to do here at the healthcare system is to, I don't want to say beef up our intensive care unit, but to try to provide coverage 24 hours a day. It's really difficult to find individuals that are intensivists working on the ICU. So we've been really happy with this new group that started several months ago, a year or so ago, that have been able to provide us coverage. And it just happened then that we got into COVID, which we'll talk about later. But maybe, again, just tell us a little bit about your group and what you do.
Sure. Well, first of all, I appreciate you guys having me on this session. Dr. Fadul, I'm a pulmonary critical care physician, as Dr. Coase pointed out. I've been in Ohio since about 2011. I was initially working at Cleveland Clinic. And after that, I was at university hospitals and eventually made my way to Blanchard in about 2017, I want to say. Initially part-time, and frankly, I fell in love with the hospital, fell in love with the community, and became full-time. And I loved it so much that I invited a lot of my friends to join. So our group is actually pretty robust. We have 4 pulmonary critical care physicians, as well as 2 advanced nurse practitioners. I'll just run through them because they're all excellent. So Dr. Johan Lopez, he's the director of critical care. Dr. Claire Rimmer, who came to us from University of Rochester. Dr. Ajit Chari, who came from LSU. Kim Geckel, who's a nurse practitioner who's been here she's frankly an institution. She's been here for quite some time and has really been a pillar of this program. And Becky Link, who's one of our outpatient nurse practitioners. And again, also, just a pillar of the outpatient. So pretty robust team. We focus on both pulmonary medicine, which is lung-related illnesses and lung conditions. And we do critical care as well. So if you're sick or critically ill for whatever reason, you're gonna see us. We're the ones who are tasked to turn you around and make it better. So our domain is really both in the outpatient setting. We do the lung medicine for the most part, and then in the inpatient setting, we do pulmonary consultations, but our bread and butter really is the intensive care unit.
Thank you. And a reminder for anyone that has any questions, feel free to send those in to us. We'll try to answer them as we go. As I said, our plan today is to talk about some of the testing and things we can do here. One of the questions that I frequently get, not just related to pulmonary, but a lot of the other services that we handle are, what can we do at Blanchard Valley Hospital in the healthcare system? When do I need to be transferred, or should I go? Talked about Cleveland Clinic. When do we need to make referrals, or should I make those kind of referrals? So we will be touching on those sort of things. So let's talk about the specific testing that we can do here. What does a pulmonologist do as an inpatient or as an outpatient if they're looking for lung disease? What kind of capacities do we need?
Sure. So really, we can handle just about everything that comes our direction. And if you've met me before, you've probably heard me say that I want this community to really be, the pillar of pulmonary and thoracic health within 100-mile radius in any direction. And I really view the institutions that we look at as kind of big brothers, as like the OSUs and Cleveland Clinic. But really, realistically, we can handle just about everything here. And we only will transfer you out if we see that there's something that we can't offer you here, or that there's something some modality or treatment that we don't have available to us. But generally speaking, we have pretty much everything available to us here, with very few exceptions. So in terms of the outpatient stuff, what we tend to focus on is general pulmonary, so any kind of lung issues. We often see patients with shortness of breath without cause, and we're the ones who kind of differentiate as to what that is, or chronic coughs, or an abnormal chest CT scan or an X-ray, and it's on us to kind of investigate what the cause of that is. What we've done recently is we've implemented our subspecialty clinics, really to kind of drill down and focus on care where it's needed the most. So we have, in that regard, we have an obstructive lung disease clinic, which is consisting of COPD and asthma patients. We have a lung nodule program, so we're screening patients who have higher risk for lung cancer in advance. So if, God forbid, there is one, we can catch it early, identify it early, treat it early, and make it a non-issue for this patient moving forward. As the world changed, we actually developed a COVID-19 clinic, with the idea being that we can manage patients even remotely through telehealth modalities and monitor them at home, so that A, they're minimizing their risk to themselves, and B, they're minimizing the risk to other patients and other community members, whether they don't have to go to the doctor's office to be seen. We can do that in a telehealth capacity now. We also have a pulmonary embolus clinic, which is basically, it's a fancy way to say a blood clot in your lungs, which can be life-threatening, and frankly, many people die from this. We have a clinic focused specifically on that management, and that starts actually even in the inpatient setting. So that's typically how those patients will present to us, is they'll have pretty severe presentation of shortness of breath or chest pain, and they'll come to us from the inpatient setting, and then we'll steer them through those kind of rough waters, and then we'll follow them through our clinic until they're back to their baseline. That's just an example of some of the things that we have. We also focus on occupational lung illnesses. We have a lot of industry in the area, and sometimes there's exposures that need to be addressed and need to be evaluated. We have the capacity to do all that here. So really kind of drilling down into the subspecialty clinics and really meeting our community where you're at, and making sure that we can provide to you the best possible care.
So it sounds like we've got a lot of modalities. A lot of those things are new things that we're talking about. One of the questions we had that had previously been sent in was someone was asking about their father, 82-year-old, that had been diagnosed, let's say, with anxiety causing shortness of breath. With that being said, if that person would come in, what's the start of the kinds of tests you do, and what's the algorithm or the criteria you go through to make a diagnosis? What kind of test might be done?
Right. So that's a great question for whoever asked that. And anxiety in and of itself can cause shortness of breath, but it can also overlap, because you can imagine if you have COPD or you've got some other issue that's causing shortness of breath from some other physiologic cause, that's going to probably produce anxiety that you haven't figured out what that is, and you can't breathe, frankly. So they oftentimes exist in the same patient quite frequently. So when we get a patient who's got shortness of breath and it's undifferentiated, we don't know what the cause is, the first thing is really just a deep dive, trying to understand, tell me a little bit more about that. When does it manifest? What makes it better? What makes it worse? Really understanding the kind of the dimensions of their symptoms. And we have a full functioning pulmonary function testing lab here. So not only that, but I can now test you and say, okay, I'm going to put you here. I'm going to see how your breathing pattern works, how well you exhale, how well you inhale. Is there any signs of obstruction? Are there any signs of restriction? So we have that modality here. We have a top-notch pulmonary function testing and respiratory therapy group here. So that's probably step one. After a kind of a deep analysis of the history of this illness, as well as a good physical examination. From there we have full range of imaging modalities available to us. We have very basically chest X-ray. We do chest ultrasound in the office right there on the spot, which takes 2 seconds. And we've got the ability to do CT scan or PET scan, and as appropriate MRI, which is less common for lung stuff, but we have that available to us nevertheless.
One of the other questions that we got, and thank you for that information, just about asthma in general, if there's anything new in asthma or things that you would talk about that someone might be interested in. The specific question was, is there anything that I can do if I have asthma to reduce the chances of having an asthmatic attack? And I think one of the questions, we'll talk about COVID later, but just the exercise-induced asthma, participating now in sporting activities and things like that. Any comments?
Yeah, it's again another great question. So with asthma, one thing is trigger avoidance, right? And we tell that across the board to all of our patients. So if you know that being around certain smells or scents or doing certain activities is going to trigger an exacerbation or a flare up of your asthma, to the extent that you can avoid it, that's probably the best thing. If you can't avoid it, prophylactically using an albuterol inhaler to give you some to help open up your airways in advance is one of the main things we recommend. In terms of other treatment modalities that are out there, this is a constantly evolving process. So we have an array of inhalers that are at our disposal to try and minimize the inflammation in your lungs and help open up the airways so that these exacerbations either don't occur, or if they do occur, they're minimized in how much you feel them. And then now we're seeing there's an evolution of what's called biologics. So for patients who have refractory asthma, like you're on the maximum inhaler therapy and you're still having exacerbations, there are injection therapies that are available to you as well. For those patients who have allergic atopic asthma, there's also therapy for that as well, with biologic agents as well. So it's a constantly evolving field. There's always something new coming out, and as I mentioned before, we have all that at our disposal here. And specifically with asthmatics and also with other conditions, we have the ability to monitor. So even though you may feel good or maybe you don't feel good, we can check right there on site in the office, and we get a result within 1 minute. Your nitrogen oxide, which is it's a sign of inflammation in your lungs. So we can test it right there on the spot and tell you, okay, your lungs are adequately controlled, or they're inadequately controlled. We need to do something differently. So it's a dynamic picture. We take into consideration when we're managing this, what are your symptoms? How are they manifesting? What are your current therapies? What have you tolerated? What have you not? And then these diagnostics like the nitrogen oxide, for example, and other tools at our disposal.
So moving on from asthma, at least when I was trained a long time ago, concerned about someone that wasn't well treated or poorly compliant, asthma could move to COPD. There were several questions about COPD, and we'll talk about smoking in a minute. But is that still the case, that if you don't take care of your asthma, that you can turn up with what we call COPD?
Right. So for by and large, no. Okay. Now, with that being said, every time I have an asthma exacerbation, let's just say that my lung function before my very first exacerbation was 100%. When I have an exacerbation, I'm not going to return exactly to 100. I'll return to 99.5, and so on and so forth for every subsequent exacerbation. So the difference, at a high level, the difference between asthma and COPD is that asthma is reversible airway obstruction, whereas COPD is irreversible. This is chronic damage that's done over time. Now, with that being said, I said there's no overlap, but there is actually some, in that if I have repeated exacerbations of my asthma, there can be a long-term deficit as a result of that, which is why it's super important that we be very aggressive about managing your asthma and making sure that we're not having those frequent exacerbations, and we're keeping your asthma in check, because we don't want to have those long-term consequences of decreasing lung function.
And so from a standpoint of chronic obstructive pulmonary disease, do you want to comment about smoking from a standpoint of prevention for COPD? And then a common question that I would get asked as well, does it make any difference after I've gotten this? Does stopping smoking help? Is it never too late to stop smoking? Comments on that?
Yeah, we get that question a lot in our clinic, and I'm glad you brought it up now, because I want to get this out into the Facebook stratosphere here. So obviously everyone knows that smoking has an impact on COPD. So it's causal of COPD. There are also some cases that there's a genetic condition that can cause it as well. That makes up, just a few percent. So we'll leave that to the side, and we actually screen for that with every patient that comes in. So we'll know who has it and who doesn't, that genetic condition. With that being said, smoking, has a whole host of problems with it, not just lung related, also cardiac related, dermatologic, neurologic, everything. So it affects a lot of your systems because of the carcinogens that are inside the cigarettes, right? So we don't want anyone to smoke, and I'd be happy if our clinic was 0 patients. I don't want anyone to smoke, frankly. But if you've smoked and you've developed COPD, absolutely there's value in quitting. Absolutely, 100%. And the example, I write this out if I have a patient in front of me, but let's take that same example of I'm starting off at age 20 with 100% lung function, and I start smoking, my lung function is going to go down. But the problem is, well, I guess I should be going this way, right? I'm looking at it. So now I quit smoking at age 50, right? Well, my lung function is not going to go back up. I've already lost that lung function. But the difference is I'm no longer declining at this rate of speed and losing lung function, right? I'm not losing quality of life, the ability to breathe, the ability to engage in activities that I would ordinarily do without difficulty, going for a walk with my kids, that kind of thing. Now if I continue to smoke, I'm going to continue to lose lung function at a very rapid pace, and to the point where I'll need oxygen or ventilator devices, and quality of life suffers significantly. So you don't regain lung function when you stop smoking, but what happens is you level off. So you resume losing lung function at the same level, at the same frequency as the version of you that never smoked, right? So if you're losing 1% a year, instead of going from like 5 to 10% a year while you're smoking, you're back to losing 1% a year. So absolutely, I strongly encourage you to anyone who's listening to this to quit smoking. The benefits are significant, and we have, and to that end, I mean, we have tools at our disposal there to help you with smoking cessation and quitting smoking. It's not easy. I mean, I tip my cap to the people who can do cold turkey, but that's not the majority of us. So it's a tough habit to kick, and that's by design. I mean, the cigarette companies, they want to make money off us. They want you to keep on buying cigarettes. They make them addictive, so they make it hard to quit. So to the extent that we can be helpful to you guys with respect to medications or cessation counseling, which we have 2 registered team members in our clinic that help with tobacco cessation counseling. We want to be that crutch and that support for you guys.
So if I were a smoker and wanted help, this is something you'd help me with in your clinic, get me into a plan, medication or referral or whatever?
Absolutely. Yeah. We would keep you here. We wouldn't even refer you. So, when we look at these disease states, let's take COPD, for example, really it's a comprehensive thing, right? So it's not just, I'm going to do a breathing test on you every so often and give you some inhalers. I'm going to make sure that your nutrition is good. I'm going to make sure that if tobacco cessation is an issue, then we're going to help you quit smoking. And that's going to come up every time you talk with us, because we look at your health as a partnership. We're in this together, right? So, we want our patients also pulling in the same direction as us. So, and some of my patients will probably say I'm annoying about this, but I will annoy you every visit about quitting smoking if you haven't already. I'll do it pleasantly though. But getting back to kind of the comprehensive care component, we also want to think about, okay, we talked about nutrition, smoking cessation, screening for lung cancer, right? There's an association there. We want to think about getting appropriate vaccinations, whether it's the Pneumovax or whether it's the flu vaccine. These are all things that we need to be mindful of for our COPD patients, because by virtue of the fact they have COPD, their lungs are a little more delicate than the average person, right? Or the version of that person without COPD. So we need to take extra precautions to monitor your health, not just strictly as a COPD patient, but as in a comprehensive way, looking at you as a whole person.
So along those lines, one of the questions was asked, what causes lung nodules? So that's a generic high level, maybe related to COPD, but maybe you could talk to us, what's EBUS? Someone asked about that. Now, I've been a smoker for 20 some years. And is there any worthwhile testing to prevent me from getting lung cancer, or I guess more likely to find it early? If you want to comment on what we do here about that.
Yeah, absolutely. So, so nodules at a high level can be anything from kind of benign old scarring, which is, believe it or not, super common in Ohio because of what's called histoplasmosis. It's a fungus that lives in the dirt and it's aerosolized and it gets in our lungs. So if you engage in outdoor activities like gardening or hiking, you're probably prone to have inhaled some histoplasmosis at some point in your life. So it can be very benign, or it can be, it could be cancer or anything in between. So we take nodules very seriously. That's why we have this nodule clinic. And as you're aware, the earlier we identify cancers, the earlier we can treat it, the better the outcomes, right? So the goal for us is to catch cancer as quickly as possible and have a very short time to diagnosis. So the time that we identify it on imaging. We want to very quickly diagnose it and start treatment thereafter. In terms of EBUS, so EBUS stands for endobronchial ultrasound. This is EBUS for short because it's a mouthful otherwise. It's a non-invasive way to diagnose cancer. So the quick and dirty of what it looks like is, you're sedated. What we'll do is we'll put a scope through, typically through a breathing tube. You're asleep for the whole thing, so you won't remember it. And we'll use there's an ultrasound at the end of the probe. So historically, it used to be that we were just kind of jabbing needles into the lung based on what the CT scan showed, and like we're trying to get into that ballpark area. Now we have the ability to use 3D imaging and use real-time ultrasound to project exactly where a lymph node or a nodule is, and take a very direct sample. So what ends up happening is what used to be a 2-hour case in the OR is now maybe 20 minutes. So because we can do it so precise and so safe. And in that procedure, we can do both diagnosis and staging. So we've limited the amount of exposure you need to get to anesthesia. We've limited the risk of doing the procedure, risk of bleeding. And again, it rapidly gets you to time to treat if treatment is necessary. And our hope, obviously, is that these are benign, but there's a certain portion that are not. So we pair that. That's called advanced diagnostics. We have an advanced diagnostic program that pairs with lung nodule clinic. And the nodule clinic, that's really guided by the USPSTF, the United States Preventive Services Task Force, which issued guidelines along with our professional societies about screening. So based on your smoking history, and if you're still smoking or not, that in and of itself is a justification for screening for lung cancer, because you're at a higher risk, unfortunately. So we monitor patients based on that alone.
So how often would you check me? Let's say I've smoked 25 packs per year, or not per year, but 25 pack years. There are criteria of how often you would look at me, recommend the CT.
Exactly.
And then you put me in a program.
Correct.
Even if I quit smoking?
Correct. Yeah, even if you quit smoking, and again, it depends on when you quit smoking. But so typically we'd screen people on a yearly basis, and it takes virtually no time for a CT scan. It's about 5-10 minutes. I think it's more time to register than it takes to get the low dose CT scan. And from there, really, we kind of guide the frequency based on what we find. So if we find nothing, then you're kind of off the hook, right? But if we see something that's suspicious, we may decide just to monitor it at a shorter interval, maybe 3 months, 6 months, or alternatively, if we want to go ahead and get a sample of it, we'll try and find a non-invasive way. And I've described one way, but we actually have a pretty robust service around diagnostics here and therapeutics that are outside of our pulmonary clinic, including interventional radiology. So they can actually, if there's a nodule that's kind of far out to the side here, they can just go from the outside in really easily, quickly and painlessly, and get that same sample. We also have a great thoracic surgery program here that Dr. Pete Rossi heads up. And if it requires something a little more invasive, or maybe even a resection, we have a great team to do that as well.
And again, the important point for those listening is finding this early. Lung cancer, back when I was practicing, was not a good diagnosis to make. We really can make a difference on what we've seen. Do you see very many of these cases? And I guess one of the other questions is, to your knowledge, does insurance usually cover this if you meet the criteria Medicare and commercials would say this is worthwhile having done, and they'll be glad to pay for it?
Absolutely. This is not our opinion or anecdotal information. This is kind of well-trodden ground, and this is a generally accepted standard of care.
And I guess my second point, do you see very many of these people? Are we seeing people come in and want to be screened? And we have found nodules that we're doing EBUS. We find quite a bit. I'd like to find more now, frankly, because the sooner we find it, the better the outcomes, as I said before. So you'll see probably in the community, you'll see a greater emphasis coming out about our nodule program and what we're doing to really streamline care and make sure that we're providing the best care in a timely fashion. But we're catching quite a bit, and we're seeing good outcomes, which is
which is the goal. So, I think we're just super lucky in this community because we have a great oncology team. Dr. Ashraf, Dr. Thomas, they're fantastic. We really enjoy working with them, and they're probably some of the most compassionate doctors that I've ever met, frankly. So, we have the nodule clinic starts with us, but it continues with them, and it's a really seamless flow, and it's a great program we put together.
Thank you. So before we move to COVID, is there any just general comments, questions were asked? Does dietary make any difference? So let's assume I don't have any lung disease or one of my grandkids. What's the best thing to take care of your lungs for your lifetime? Does nutrition or specific foods make any difference? And likewise, exercise. What's the best prevention? Just take care of your lungs.
Yeah. So I think, the first thing is probably, toxin avoidance. And this isn't just, like the low hanging fruit here is cigarettes, cigars, vaping, avoiding all that stuff is, definitely you should do that. And that's probably, the number one best thing you can do. But we actually have environmental factors that are associated as well. So, I most recently lived in Cleveland for the past 10 years, and the air quality in downtown Cleveland is not the greatest. So that actually impacts and it can influence, asthma exacerbations for local city inhabitants. And we see that it's well documented. So, environmental agents are something to be mindful of. In terms of nutrition, there's anecdotal information about, eating this food or that, that the evidence is not really the strongest for that. If in terms of activity, deep breathing activities, yoga, I'm a big proponent of, that's basically, focusing on deep breathing and that actually has a benefit to decrease what's called atelectasis, which is kind of collapsed lung areas. So, but frankly, deep inhalation from anything, right? Whether you're doing it in exercise and jogging, that's all good for your lung health. So we strongly encourage that. And overall, the lungs themselves are not, they're not a muscle, but they're run by muscles, right? So we have muscles in our rib cage that help us breathe, and we have our diaphragm, which is our biggest muscle. That helps. That's the main driver of breathing. So making sure our nutrition overall is good, making sure our physical capacity and strength is good. That's all going to influence. That's going to influence your ability to prevent pulmonary issues in the future and lung issues in the future, and focus on your lung health.
Good, thank you. Before we move to COVID, any questions from our audience?
Sure. We have one concerning asthma. Can you have asthma and it not show up on a PFT test?
Yes. So typically when people talk about PFTs,
go ahead. Make sure PFTs, everybody knows what that is.
Yeah. So when people talk about PFTs, that's the shorthand for pulmonary function testing. So and I'll very quickly, the quick and dirty version of that is we'll put you in a box and have you breathe in deeply multiple times and breathe hard and fast to see how well you exhale and look for obstruction. So I mentioned before that asthma is a reversible condition. So when you're doing that, unless you're having an exacerbation right in that moment, you can miss it. So what was developed years and years ago was something called a methacholine challenge. So basically we give you a trigger and we try and essentially trigger an exacerbation, trigger an obstruction in your lungs, and then we relieve the obstruction at the end of it. And even that's actually not 100% because there are patients for whom exercise-induced asthma is the trigger and not necessarily like an inhaled stimulant. So there are cases where you can have asthma that is missed on pulmonary function testing.
Any other questions?
Yes. Concerning lung nodules, I've been told that they're often harmless. However, when should I become concerned about lung nodules?
These are great questions. I'm really impressed with how thoughtful these are. So with nodules, there's a lot of issues that we take into consideration, namely the size, the rate of growth. That's why we follow it over a series of scans over time. The dimensions of it, if it's kind of like purely round and doesn't look kind of angry with little spiculations coming out in every direction, that generally lends it to be more benign. So it's really we look at that's just some of the parameters. We look at all of these things together, and then we may still want to do a biopsy if it's kind of like borderline. So yes, by and large, I think the majority of lung findings, if I were to scan everyone in Finley right now, you'd probably find more benign things than malignant things or scary things. But we continue to monitor them just to make sure that they stay benign and they're not scary. And if they do start getting into that kind of gray zone of, well, this could be something more, that's when we'll all kind of stack hands with our oncology colleagues who focus on cancer, with our infectious disease colleagues. Dr. Nate Rodnasamy, he's a treasure of our community here. And we'll all kind of share perspectives and analyze the case together and decide whether we want to be more aggressive and get a biopsy, or whether it makes sense just to continue to monitor at a short interval and just kind of keep an eye on it.
Okay. Jen, anything else?
We do, but it's concerning COVID.
Okay, so let's move to COVID. What we'd like to do is walk through a typical patient or an experience, or how do we make decisions, and what are we able to take care of here. Again, we really appreciate, and you've heard from Dr. Fadul about this has been a team sport here, working with the emergency room, with public health, and with everything else. And not maybe all patients end up seeing you with COVID. We'll talk about that, but let's start at a high level. What have we learned about COVID from back? We were sitting 4 months ago thinking we might have 400 people in the hospital, and how are we going to have enough ventilators and all of those things going on. That's not what's happened, and I think there's probably some explanations, but just the basic physiology of the virus, or what things. What have we learned? And then maybe a secondary question to that is, how do you keep up with the literature? I seem like I spend 2 or 3 hours a day just reading all these different reports. How do you get your information? Let's start. What have we learned, and how do we keep up?
Yeah, so we've learned a lot, frankly, and this is a unique time, because I don't recall in my time practicing ever that any disease state really got this much attention in the kind of the lay press and the media. So we've heard a lot about different studies, and because everything happens so rapidly. I mean, typically when you think about other disease states, there are trials that last 2, 3 years, 4 years, and there are very large populations of patients, so we can really get good data. Because this was evolving so quickly and it was spreading so quickly, really we were relying on smaller studies that were not what's called a controlled study, where you have a group you don't treat and a group you treat. We were just kind of relying on what anyone who had experience was saying. And oftentimes, because of where this originated, it was coming from Asia, it was coming from Europe, and then finally it came to the US. So now we're seeing more data coming out of the US. But initially we thought there was a question of, is hydroxychloroquine beneficial? Is azithromycin? There was various studies that analyzed this. The data was always equivocal. We thought that because it was a pulmonary issue, that these patients were all going to end up on ventilators. And then we thought it was going to be similar to what's called ARDS, which is kind of like it's acute respiratory distress syndrome, which is basically the kind of like end stage and lung findings. And frankly, it wasn't like that. The physiology just didn't behave the way we all anticipated it was going to, 4 or 5 months ago. And maybe for the better. I think we're seeing now over time that mortality has started to come down. And this could be due to many things. Obviously, there's more testing now available, although it's still not enough. But I think the treatment has also evolved. We've understood this a little bit better. And now, and in terms of the kind of the treatment modalities we have available to us here, everything that's been approved, that's even been kind of remotely positively spoken about, save for ECMO, and which we haven't really just, by staying on top of it. So, on a daily basis, we're internally, we're all kind of researching the CDC guidelines, any new data that comes out, our own professional societies like CHESS and Society for Critical Care Medicine, the IDSA, the Infectious Disease Society of America, all of them are publishing data and putting out guidelines fairly on a regular basis here. So we're relying on experts and the data that's out there in the field. And beyond that, we're sharing that data. So it's one thing for all of us to kind of go home do our research. But the other thing we're doing is we're not just talking to our colleagues at other institutions, but we're sharing that data here and really making it uniform, the understanding. So if Dr. Lopez, for example, digs through all the data, he just did this not that long ago. He put out a continuing medical education program so that every other clinician in the hospital has the ability to benefit from his research and what he's seen and what the literature is over the past month or however long it was since the last time one of us spoke about COVID-19. So it's gathering that information, distilling it down to useful kind of nuggets that we can actually use to treat our patients with, and then sharing it with the greater medical community.
And I would say, speaking for the medical staff, we're highly appreciative of your team. Along with Dr. Radnasamy, we had a weekly, well, sometimes twice a week when this first started, that we talked with the medical staff. A lot of questions about what are we going to do as an outpatient, how do we screen people, et cetera. So again, thanks for all the work you put in, because I know Dr. Lopez especially is prepared continuing medical education every day. Before we get into maybe some specifics, let's just talk about prevention. I don't think that's changed very much. Social distancing, respiratory etiquette, and then I'm not sure why the controversial masks as to what your feelings would be. I know we had a question about there may be some reasons why someone shouldn't wear a mask, or they might have contraindications. You want to just comment on masks in general? I think everyone would be aware that what the governor has said, we require everyone here at the hospital to be wearing a mask unless they're in their office by themselves. And we see it as part of our responsibility. Again, a mask is worn to protect. If I have COVID, then I'm not giving it to you. It's a kind of an etiquette thing, a duty, whatever. But anyhow, are there reasons why somebody shouldn't wear a mask?
Yeah, well, I think the less controversial ones, the social distancing.
Yeah.
Let's start with that first. The reasoning behind that is every time, even when we speak, little particles come out of my mouth, right? And if I have COVID, I don't want to aerosolize it and give it to the entire room. And that's the reason why kind of, denser humidity areas don't have it as much or I have to worry about that less because the air is a little thicker, so that particle of spit is not going to go as far. And that's why, frankly, we're observing social distancing here right now for that exact reason, is that we want to make sure that we're keeping appropriate distance so that when we're chatting, we're not conveying anything back and forth. Although obviously both of us are negative, we're still showing that courtesy. In regards to masks, and hand washing. I'd say this is mother's advice, right? My mom told me to wash my hands all the time, and that's probably good advice for all of us right now. So before you're eating dinner, before you keep your hands out of your mouth, that kind of thing. These are all kind of basic common sense things that our mothers and fathers told us when we were young. That I think they carry a lot of weight and a lot of value nowadays. In regards to masks, again, I think this is an issue that people have some misconceptions, and there's a lot of data that's out there that's probably not the most accurate. The masks are beneficial, and I know that there's some resistance. People don't want to be kind of told what to do, and I don't like being told what to do. But I also realize that this is it's important to prevent this from something bad and turning into something horrific for the entire community and ourselves. So there's a tremendous value in wearing the masks. The question came up a couple times actually in our clinic about are there problems wearing the mask because I've got COPD or I've got asthma or I've got some lung condition, and the mask is not good for me. It's just the opposite. Because you've got these lung issues, you're the kind of patient, if you've got lung issues or other underlying medical issues, that I want you to wear the mask, because if you get sick, God forbid, you're going to get a lot sicker than everyone else, right? Than the same version of you that didn't have those medical conditions. And so it's actually more important that you wear the mask if you have those conditions. So there are some people who feel as though, like, I've got asthma, I've got COPD, I can't take in a deep breath. There's obviously there's different types of masks you can get. I would encourage you to find one that's maybe a little more tolerable for you. But also, if you need to take a break, just go at a safe distance from someone and take the mask off, collect your breath, get back to your baseline, and then just put the mask back on. I mean, it's ultimately, it's for your benefit and truly everyone else's, but it's also yours. So I can't tell you this enough. I'd strongly encourage you to wear the mask when you're out in public or in crowded areas. Observe social distancing. Again, this is going to prevent, an issue that is bad from turning into an issue that is truly horrible. So that'd be my thoughts on the mask and conditions that can come from the mask or contribute to it.
Okay, so let's say I'm diagnosed with COVID. We're not admitting everyone to the hospital. So any advice, or what do you tell a patient that we're going to go home? I mean, the lay have read, as well as medically we've read, sometimes people can deteriorate fairly quickly. So are there any parameters I should be looking for? When do I report back in? High level thoughts?
Right. So there's kind of two buckets that we think about when we think about COVID-19 patients, right? The mild and the not so mild, for lack of a better term. So the mild ones are the ones that, they're not requiring oxygen. They may have been even asymptomatic. And typically, if they've got resources at home, a loved one who can, if they were to decline abruptly, they can be there to help them or be there to call emergency services. Those are patients that are actually better served at home. The last place you want to be to get better is a hospital, right? So, if you can be at home, that's probably the best thing for you, provided that you're safe. And we offer the ability to do telehealth monitoring, through our clinic to make sure that that's the case. And typically we want you to be there for approximately 2 weeks, get retested, prove that you're negative, and then you can come out of quarantine. And we actually have guidelines, not just for yourself, but also for caregivers in your home that are issued by the CDC that we can share with you to show you how to lower the rate of transmission and kind of minimize the spread as much as possible. So that's that first bucket of patients that we think are kind of the mild ones that for whom it's appropriate to be at home, and we think you do well with that, and in conjunction with us monitoring, remotely, or your primary care doctor for that matter. The kind of the more sick patients are the ones that they may have underlying issues, they may need oxygen, they may have other complications. COVID is interesting in a bad way because it can affect multiple systems. It can affect your heart, it can affect neurologic system, GI tract, the whole nine. So we're really seeing it present in a lot of different manifestations. And so for those patients who are a little sicker than what we feel comfortable saying, yeah, you'll be fine, we'll just monitor you remotely from home, we want those patients to be admitted to the hospital. They may or may not go to the intensive care unit, but certainly they'll be in isolation, making sure that they're getting the best care possible. For those that do need to be admitted to the intensive care units, you'll have kind of more resources available to you. Generally, those patients are a little bit sicker, and they require a little more attention. So they have, our team kind of hovers over them when they're there. But again, the goal is to make sure that wherever you are on the spectrum of sickness, you're getting the appropriate level of care, and not too much, not too little. Again, hospitals I jokingly say they're terrible places to get rest and get better, because we'll poke you and prod you all the time. And if we can limit that and say we can manage you at home, we'd like to do that, provided that it's safe.
So do we lack capacity right now? I know when we first started with this, we needed negative flow air rooms. You can talk about that if you want to. We were concerned about ventilators or the non-pharmacological kinds of things. Are we in a pretty good shape to take care of people that come in now with COVID?
Yeah, and I'll tip my cap to our leadership team, and both at the kind of the ESC, like the executive level, and also even our department leaders, like in respiratory therapy. There was an all hands on deck effort to make sure that we had all the resources available to us to service the community. So when we were all kind of freaking out, frankly, about 3-4 months ago, because we heard these projections that were going to show, hundreds of patients at a time coming in here, our teams were immediately focused on sourcing the equipment that we needed to provide the best care possible for the community, and they procured all of it. So we've got the ability to manage, if there is a surge that comes with this fall, which there's probably going to be some with flu, and to what extent COVID's going to play a role in that, it's anyone's guess at this point. But we'll be ready to treat anyone that comes in with the best care available anywhere in the world, right here in Findlay.
So let's just talk a little bit about the treatments. You mentioned hydrochloroquine, some of the antibiotics had been used, and I know that's evolved. I think we've learned more. I personally would say I don't think anybody probably when it started thought that they were doing anything wrong. This is what we thought maybe would be good treatment, but we have learned. So what are the mainstays of treatment? Remdesivir, do we have that available? If you want to comment on plasma, do you think that's effective? And maybe talk about dexamethasone. Dexamethasone's been around forever. It's a steroid. Why did we decide this might be useful? And maybe just make some comments on, we have the availabilities that everyone else has, and why we use them.
Yeah, absolutely. So there's a big joke in the pulmonary community that every time there's a new disease, someone tries to cure it with steroids. So, and this is no exception. So, but taking a step back and you think about, COVID, it's got an inflammatory response to it. So the idea was that, and we saw patients who kind of declined, around day 8 or so after getting sick, they were having these inflammatory responses that, it was opined, it was thought that steroid ability to kind of dull that response would be beneficial for the patient, and the data seems to support that steroids are beneficial in that capacity. So for our cocktail here at Findlay, that's part of the standard therapy is getting Decatron or dexamethasone. The two other therapies you discussed are also available here, and they're also ones that we use routinely for our sicker patients. Remdesivir is the antiviral that's out there. We have that as well at our disposal. Our pharmacy team has procured that. It's not widely available in the rest of the country, unfortunately, but we have it here. And convalescent plasma. And so what convalescent plasma is imagine I get COVID and I get sick, and you and I have the same blood type. I get over it. I've developed antibodies to COVID, so it limits my chances of getting it again in the future. But now if you get it, and you don't have antibodies the first time you've had it, I can donate my plasma, which is now antibody enriched, to people who match my blood type, and essentially give them my antibodies, right? And that it's another tool in our war chest to help fight COVID, and patients do well with it. The good thing is it's still scarce. But as the number of patients grow that have had it and beaten COVID-19, the number of potential donors also grows. So, and I encourage everyone to if you've had COVID-19, please consider this. I think this is a benefit to your fellow man at this point. So, the more people that have had COVID in the past, they can then donate that plasma, antibody enriched plasma to other patients, and we have that ability here. Again, it's fairly scarce, but our pharmacy and lab teams have done a great job of procuring.
So they've been available when we've needed them,
and we've used them quite frequently.
So assuming I survive this and I've had COVID, what concerns are there long term, or that's individualized, or are we far enough along? Is it gonna really exacerbate or make my COPD worse? What do we have feelings about that?
Yeah, so it's still in some regards it's still a little bit early to tell, right? I mean, this became an issue just a little less than a year ago, and so we've not really seen kind of longitudinal data really play out yet, but we do know there are a lot of complications, and that's something that we're kind of in our COVID clinic, we're running quarterback on that. So there are patients who they've had COVID. We've managed them, via telehealth. They're out of the hospital, and they're coming now with complaints of, something that would suggest, myocarditis or like cardiac issues. Our job in our COVID clinic is to sniff that out and then get them to the right place, right? So, we're going to try and we do know that the sequelae of COVID-19 exists. So our goal is to try and really get you to the right doctor at the right time for the right issue. In terms of the COPD issue, and is this going to make my COPD worse? Again, it's the same idea of, we talked about asthma exacerbations, right? So if you've had a flare up, and you were 90% before that flare up, you may go back to 89%. You may be close to that. So it's the same kind of issue. You will take a hit, most likely. To what degree is variable. It's still a little early to tell, but we have data from other comparable infections that would suggest that there is probably going to be some small toll to lung function in the long term.
One of the questions we were asked, maybe this is more prevention, someone that had pulmonary hypertension was concerned about COVID, but I guess it would apply to COPD or asthma. What are you advising people about traveling right now? Not necessarily they've gotten over it to prevent getting COVID. Are you concerned about where they go? Or again, what would be the advice you'd give someone?
Yeah. So, again, I think common sense rules come into play here. And then also, governor's rules, which I have no control over. So, I think the common sense rules would be, probably avoid places that are, high density of COVID right now. So I wouldn't necessarily be hanging out in places that have, local outbreaks or big spreads, whether it's, local or you have to travel to it. I mean, I would avoid that. In terms of airline travel, pretty much most of the major carriers, if not all at this point, have updated their air filtration system, so it's not kind of recycled air going through and through. If you are going to be on a plane, again, use the same cautions that we recommended earlier. I encourage you to wear a mask. I encourage you to the extent that you can, maintain social distance. If you are sick, don't go on that plane, as a courtesy to everyone else who may be exposed to you. I think it's the basic common sense things, and good hygiene precautions. Those things, I don't think they should limit your ability to travel, as long as you're engaging in kind of basic common sense and doing the things that we've discussed already about social distancing, wearing a mask, et cetera.
Thank you. Questions?
Yes, concerning a COVID patient who is no longer contagious but does have pneumonia, who receives bi-weekly allergy shots, when is it safe for them to receive the shots again?
There's a lot of variables in that question. So, is the pneumonia related to they had COVID pneumonia and it's over? Is that what you're saying?
They have had COVID, but they're no longer contagious.
Okay.
They're considered contagious.
But they have pneumonia now?
Yes. That's at least how the question reads.
Okay. So if they have pneumonia now, and then the other variable is if they're getting injections. So typically those biologic agents have the ability to suppress your immune system, right? That's how they work essentially, is to they stop your allergic response. Generally, if someone's acutely ill, we don't want you taking those biologics in that moment, because we want your body to be able to fight that infection. The same kind of ability to fight infection is with also problematic with these allergic responses. So typically the guidance is, if someone's acutely ill, we don't want them to get that. So to the person who asked that question, if you have pneumonia now, I would say the safe thing to do would be to wait until that's fully resolved. You can get repeat X-ray or CT scan, typically in about 6 weeks after the event, and that should demonstrate resolution. This is a conversation. Obviously, there's specific individual variables to the person who's just asked that. That's a kind of an ongoing conversation with you and your physician, but that'd be my general guidance.
Any other questions?
Yes. Any concerns or comments you would have on school openings?
Yeah, so this is like a hot topic, right? We're all, before this session started, we were kind of just in the room chatting about our own children, and this hits home, frankly, to a lot of us. And so, I'm wearing my doctor hat, and I'm also wearing my father hat as I have this conversation. When we think about return to school, I think we have to, weigh everything, right? So there's children that rely on school for 2 meals a day. There's a statement that came out from the American Academy of Pediatrics that said, there's a huge deficit that we're creating by not putting kids back in school. So, socially, mental health wise, there's a huge benefit to being in school. Not the least of which my son will tell you is actual education. But the concern, of course, is that we want to make sure we're doing it in the safest possible way. Generally speaking, I would say, we got to figure out a way to get kids back to school. And we want to do it in the safest way possible. But I think the end goal should be get them back to school, because I think we're setting ourselves up for long-term problems if we don't address that, in a quick and effective and efficient way. And the other thing is, we don't want this to be an emotional decision. It really has to be a rational decision, because obviously none of us want our kids to get sick. None of us want our teachers to get sick. We care about everyone that's in that school building. I mean, teachers have the hardest job in the world. I don't want to be in a room of like 30 7th graders ever, right? So, I fully respect the value they provide, because frankly, education is the pillar of a community, right? But that being said, we want to make sure that we are not doing a disservice to our children at the same time. So super important to get them back to school. We just got to figure out the safe way to do that, and the way that keeps them safe and teachers safe.
Yeah, it certainly is a hot topic. I hope we have metrics and things that we look at. The American Academy of Pediatrics did come out saying it's really important to get K and 4 back. Part of that is the difference between individuals in our society, of making sure the social determinants and the things that you talked about, being able to grow up, and then the other concern is, and I've heard it talked about, well, these kids aren't going to get that sick anyhow. That may or may not be true, but then they can also give it to someone else, and worried about grandparents about what's going to happen. So it's a tough societal problem, and hopefully, again, we'll use some metrics. Jen, any other questions?
Sure, I think we have time for one more. When is it safe for someone to get the flu or pneumonia vaccine after having COVID with pneumonia?
And maybe just to add to that, you've already mentioned, someone asked about vaccinations in general. Should we have, we'll say afterwards, but just in general, what's the advice for lung disease and COVID, what we should make sure we're getting?
Yeah, so there's taking a step back, there's generally two kind of buckets of vaccines, ones that are live and ones that are basically dead. We generally want you to be, again, if you're resolved from your issue, we want you to go ahead and get those vaccines, particularly if you have underlying lung issues, because again, you're at a higher risk that if you develop a pneumonia, let's say I'm a smoker for God knows how long, and Bill's a never smoker. We're the same age. If I don't get that, if I get the same pneumonia as Bill gets, then more likely I'm going to have a very bad outcome than Bill would, right? So it's super important for your benefit that you take these preemptive measures to protect yourself. I wouldn't say wait a prolonged period amount of time to get pneumonia vaccine or the flu shot. We're getting into flu season right now. I'd encourage you to do that. The flu shot is based on previous year's strands, so there's always some variability associated with that. But nevertheless, it's a good thing to get.
Somebody asked me the other day, there's a couple of pneumovax vaccines out there. We have pretty much settled on which one everybody recommends now?
Yeah, it just really kind of depends on the patient and their comorbidities. Okay. But again, that's part of the kind of the comprehensive care that we provide. That when we think about managing our patients, as a whole person, not just like COPD, right? We think about you in entirety.
Well, I appreciate you saying that. You might do worse than me, but I'm about 30 years older than you are. So I think that makes a little difference too. Last question. You think we're going to have a vaccine for COVID by first of the year? Any guesstimates on that?
Yeah, I wouldn't hold my breath.
Okay.
And the reason is typically the vaccine development process typically takes, on the short end, 12 to 18 months. Yeah. The fact that we're not going to get one doesn't mean that, all is lost. Frankly, treatment has gotten better over this time. So yeah, we don't have a vaccine to prevent it, but treatment modalities have gotten better and mortality is going down. But it does underscore the point that we really need to be mindful of our engagement and interaction with each other. The things we've talked about ad nauseum already about wearing a mask, social distancing, using the basic hygiene precautions. Think about what your mother said to you or your dad said to you when you were a kid. I encourage you to kind of listen to those common sense advice suggestions now. So,
Rafid, thanks for being here. The hour has gone fast. I hope it's been enjoyable for everyone. Again, we appreciate feedback. I think our next Live and Learn is right now scheduled for sometime in October when we're going to talk about women's health. But again, we appreciate feedback. And if you have other questions,